I wanted to welcome everybody today. This is our COVID and cancer series. And today we will be having a COVID update part 2 with Dr. Cardinale Smith. And we are absolutely thrilled to have her back. As some of you know, she did speak with us in the spring, and it was fantastic and so informative. You all had really, really great questions. For those of you who were not with us, I'm just going to read Dr. Smith's bio, just so you know how lucky we are to have her with us today. So Dr. Smith is an associate professor of medicine in the Division of Hematology and Medical Oncology and the Brookdale Department of Geriatrics and Palliative Medicine. She is a medical oncologist and palliative care physician whose clinical practice is focused on lung cancer and palliative care. Her research interests focus on doctor-patient communication, evaluating treatment disparities in cancer care, determinants of cancer patients' quality of care, characterizing barriers to optimal cancer and palliative care, and developing approaches and eliminating those barriers among racial and ethnic minorities. Dr. Smith has had numerous publications in peer-reviewed journals, and in 2015 was named one of the top 40 inspirational leaders under 40 by the American Academy of Hospice and Palliative Medicine. So again, as you will see, we are very, very lucky to have Dr. Smith with us today, and we are going to turn it over for the next hour-ish. We are in your very capable hands, Dr. Smith, and thank you again so much for taking the time out of your extremely busy schedule to speak with our gynecologic cancer patients today.
Sure. Thank you for inviting me back. It's always appreciated. I have some slides to share. A couple are repeats from when we did this the last time, but I figured some of this information is always good to hear a second time around. And of course, you can feel free to stop me in the middle if you have any questions, or if you want to type in additional questions that come to mind while we're chatting. I'll take a look at the chat box. So hopefully you can see my slides okay? Okay, great. So just to give you the current status of COVID-19 in the country and in New York, in the United States, we have vaccinated 380 million total doses have been given, which equals 179 million people. Sorry, I can't stop my phone from ringing. It means we have about 54% of the country is considered fully vaccinated, and fully vaccinated means that you've gotten 2 doses of either Moderna or Pfizer, and you've gotten 1 dose of Johnson & Johnson. In New York, there's been a total of 25 million doses that have been given. That equals 12 million people who are considered to be fully vaccinated. That's about 62% of all New Yorkers, and this is the state, so not just the city. We have a 7-day rolling average in New York City of 3%, and I just picked Westchester thinking of where people live in terms of closest counties, and outside of New York City, Westchester is at about 2.6%. And the good news is that both of these have sort of they're either plateaued or decreasing, so they're not increasing. Of course, today I live in Westchester, and so I've been driving into work these past few days. Since the pandemic started, and totally forgot that today was like everyone back in person in the city. And so what was taking me like 35, 40 minutes took me an hour and a half. I wanted to cry. But New York City schools went back in person today. The city workers are required to go back in person today. And many offices in New York City also started in-person work again today. So a busy, busy day in the city. Hopefully, I'm not looking forward to what my commute home will look like, but we will get through it. And I think questions about, what will COVID look like for us in the upcoming weeks. I think if we're going to see an uptick, either based off of people recently coming back from their vacations at the end of summer, at the unofficial end of summer, I should say, folks who did things for the Labor Day weekend, and now with the largest portion of unvaccinated folks being our children, 5 through 12 and under, going back into school in person. If we're going to start to see a rate of increase, it should be within the next 2 weeks or so for us here. And so lots of questions about the vaccines, the first one being, are the vaccines safe for people with cancer? And while the trials, the clinical trials or the research trials that evaluated how well the vaccine works, what we call the efficacy, did not include many patients with cancer, there's no reason to think that the COVID-19 vaccines are not safe for people with cancer or would cause any additional burden or harm to a patient with cancer. We know that really the main reason why someone should not get the vaccine is if you've ever had a serious allergic reaction to the ingredients of the vaccine, and the one that seems to have the highest risk of any kind of a reaction is what we call polyethylene glycol. And that's in several things. It's an additive in several things, but if someone's had dermatologic procedures, for example, fillers, there are other things in which this is in, but it's not common and very rare. And so what's new about the COVID-19 vaccines? Well, the Food and Drug Administration, first, I should say, Pfizer is now no longer emergency use authorization. It is a fully approved vaccine. So that's one. Moderna is going to go for their full approval probably at the end of September. And the FDA expanded the use to allow an additional third dose of the vaccine for people with moderate to severe immunocompromised immune systems. And so these would include people who are undergoing active treatment for cancer, someone who may have just recently completed treatment for cancer within the last 2 to 3 months, or someone who's had a bone marrow or stem cell transplant within the last 2 years. And there are other indications under that. I'm only including the cancer ones because we're here in the cancer context, but certainly if someone has any immune compromising conditions such as HIV or AIDS, any of the rheumatologic issues, on any medications that we know suppress your immune system, like certain patients with inflammatory bowel disease or rheumatoid arthritis who are getting certain types of treatments may be considered in this category. And we call it an additional dose when it's given for this case and not a booster. And we call it an additional dose because we know, unfortunately, some folks who have immunocompromised immune systems don't have as a robust response to the vaccine as someone who has a competent or a normal functioning immune system. And so this third dose is really to get those folks closer to where those of us with normal immune systems get to after 2 doses. And so that's why that one's not called a booster, it's called an additional dose. And it is suggested that the CDC by the end of this month will likely recommend a booster shot, which is an additional dose, an extra shot. And that is because over time, we know that immunity wanes. I think last time we were here, we were saying we don't know what it's going to look like, but everybody is sort of figuring out that we'll need to get another shot, very much like how we get the flu shot every year. And so likely for those of us who are not immunocompromised, starting 8 months after you completed the vaccine series, boosters will be recommended. As of right now, boosters are only recommended for those who received the Pfizer or Moderna vaccine. It's not currently recommended for those who received Johnson & Johnson, and that's because there's no data as of yet to support the use of a booster in that population. It's also recommended that your booster or your additional dose be the same vaccine that you received previously. So if you previously got Pfizer, that third dose, whether it's a booster or additional, should also be Pfizer, and the same for Moderna. I would add that we are coming up on flu season, and in fact, the health system is getting their flu shots this week, or the flu vaccines are arriving this week to be able to start to give out end of this week, early next week. And I've been getting lots of questions around, should we get the flu shot and the COVID vaccine at the same time if we're due for our additional or booster dose? And what I would say is that the answer is you can get both shots the same day, one in each arm. So you wouldn't want to put it in the same arm, but you would want to put it in different arms. I think I will say I personally am probably going to do my flu shot a week apart from whenever it's my time to get my booster shot. And the reason I'm doing that is because I usually get sort of achy after a flu shot. And I know I felt achy and sort of napped for a couple of hours after I got my second dose of Pfizer. And so I can expect that I'm going to have that again. And I just don't want to experience it at the same time. And I think that that is an individual decision that folks have to make based off of how they usually feel after they get one of these vaccines. But you can get them both at the same time if you so desire. And so what if I'm on active treatment? Well, I think, we're trying to figure out how one sequences or times giving the vaccine with someone getting treatment for cancer. While we don't quite know what that sequence should be like, ideally, if you can get it before your next dose, sort of the week before your next dose, depending on what your regimen is, that would be ideal, because that's when your immune system is sort of up at the top of its game, and can help make those immune fighting cells that we need it to make. Of course, this is a conversation that everyone should have with their individual oncologist, because treatments are specific to the person, and I'm just making a general recommendation. So how well does the vaccine work in people with cancer? We talked about this a little bit, that, it's a limited data, at least, the way we think of our trials is the gold standard, the best of the best, is that we enroll people, we get them to participate, and then we give them the shot and we follow them through time and see what happens to them. Unfortunately, because we know not many cancer patients were included in the original vaccine trials, what we now have to do is go back and look at all those patients with cancer who got the vaccine and then see what happens to them, how many of them are getting COVID, and what's happening to them in terms of hospitalizations or ICU stay. Unfortunately, we know now that the vaccine doesn't work as well. It works. It just doesn't work as well in patients who have compromised immune system, like patients actively who have cancer, who are on active treatment for it. That's why that additional dose got approved. And so while we don't know the information on what benefit that additional dose is actually giving to folks yet, we do know that of those patients with immunocompromised systems like cancer, who got both who were fully vaccinated, that the vaccine seems to be working in about 30 to 40% of those folks in terms of preventing infections with COVID, preventing hospitalization. And that range is different depending on the type of cancer you have and the type of treatment you're receiving for that cancer. So unfortunately, of those vaccinated patients who end up in the hospital, tends to be those patients who have underlying problems like cancer or other immune compromising conditions, and also the very elderly, over 80, 85. And so are there special precautions that people with cancer should take? I think because we know that patients with cancer and those on treatment are at a higher risk of getting sick from COVID-19, if you can avoid non-essential travel, that would be ideal. particularly travel to those areas where there's high or increasing rates of COVID-19. Just recently, the CDC, so if you go to the CDC website or have someone go for you, there's a list of countries with levels of how risky they are in terms of rates of infection. So it goes from level 1 to level 4, with level 1 being low risk of infection. And the CDC is saying, it's okay to travel there if you're fully vaccinated and low risk. And then there's level 4 countries where they're saying do not go at all. And so, if you are considering taking a trip, going to that website to get a sense of the severity of rates of infection in the country in which you're considering traveling to can be helpful. Of course, you can Google the states that you plan to go to if you're traveling domestically to get a sense of what rates are like. And I'm sure you've heard on the news, there are parts of the country right now that are sort of dealing with COVID in the way in which we dealt with it here in New York in the spring, although not to such high numbers, but certainly significantly dealing with it. And I would certainly suggest avoiding travel to those areas. Certainly, if you're not vaccinated, staying at home to reduce your exposure to the virus is important. If you are vaccinated, we still recommend that you practice physical distancing to the extent that you can, trying to avoid large social gatherings with people outside of your bubble. So hopefully, the best thing that your loved ones can do for you if you have cancer is get vaccinated, because that decreases your risk of exposure. Wearing a face mask, certainly when you're indoors. If you're outdoors and you're far away from people, then it's okay if you don't have a mask, but have one on you just in case. And I saw a question here in the chat asking, is maintenance drugs considered to be active treatment? And we can talk a bit about that at the end. It depends on what maintenance drug you're on. I think that there are some maintenance drugs like hormonal therapies, for example, that would not be considered immune suppressing, but then there are other drugs like immunotherapy or chemo that we give as maintenance that are considered immunosuppressing. Okay, so what if I'm exposed to someone with COVID-19? So I think this is important. If you are exposed to someone who tests positive with COVID-19, the question becomes, what was the level of exposure? So a high risk exposure is defined as either someone who is not vaccinated and was within 6 feet for greater than 15 minutes unmasked, or regardless of vaccination status, someone who's considered immunocompromised and also within 6 feet for greater than 15 minutes. So if you fall within either of those categories, then the first thing would be to test yourself. And if you test yourself and you test negative, then one of the things that you can consider is what we call post-exposure prophylaxis. So there's COVID, the monoclonal antibody, which the Regeneron drug is what most people hear about in the news, although there are several versions of it now. It's no longer just Regeneron. But there is a medication that you can give that decreases your risk of becoming positive if you were exposed to someone who is positive. And this is particularly important for patients with cancer because you are already at high risk of developing complications from COVID-19. This can decrease not just your risk of becoming positive, but decrease the risk of having serious illness if you were to become positive. Hopefully that makes sense. And so there are two options here. If you test negative, you can be considered for post-exposure prophylaxis, which is an injection given just like we give a shot. It's unfortunately 4 injections. So 4 injections in 4 different spots, either your arms, your thighs, your belly, your buttocks, should that be a thing that you prefer. And then you're monitored for 1 hour afterwards, and that's it. If you were to test positive, you can get the COVID monoclonal antibody in the IV form, so through the vein, and that decreases your risk of hopefully of getting serious infection, serious complications from the virus. If you fall into these categories, my suggestion is that you reach out to your oncologist for a referral within the Mount Sinai Health System. Currently, we're giving both of these treatments through our emergency rooms. And so there's a referral process. Your physician has to make that referral, or someone on the physician's team has to make that referral for you. We soon hope to be able to offer this for our patients in our Uptown ambulatory cancer site. And plans are ongoing to be able to have that ready for folks as early as next week. So what else can I do to help fight COVID-19? Well, I think the most important thing is just to follow the public health guidance provided by CDC, New York State, New York City. And I know it can be really challenging because these things change frequently as the conditions are changing. But that's really the best place to go to get the updated guidance. We do highly suggest that all of those who are cancer survivors who are no longer in active treatment be vaccinated for COVID-19, again, unless you have an allergy to the components. And as I said before, having your close contacts get vaccinated is really the most important thing that we can do. So is there anything I can do to improve my general health and immune system? I think, a healthy lifestyle, everything in moderation, right? So while you should not deny yourself that chocolate cupcake, you shouldn't have it every day. And we certainly recommend that you do not use tobacco products. We know that because COVID-19 is a viral illness that infects the lungs, anything else that can infect the lungs can put you at a higher risk of complications. And so doing all of the things that we should be doing, which is eating more of a well-balanced diet that, where most of our carbs come from fruits than from potato chips, having vegetables, regular exercise, which is, like 30 minutes for at least 2 to 3 times a week, getting enough sleep. I wish I could follow that one. But then, really physical distancing and hand hygiene is really the most important thing. So since I started off this talk talking about how crazy traffic was this morning with folks returning to in-person work again today, the question is, for those who have to go back to work or are back at work, how do you do that as safely as possible? I think, certainly there are some employers who are making medical exemptions and trying to get people to do more remote work if that is conducive to the job in which you have. That's not the case for everyone, obviously. And so I think doing all of the things we talked about, making sure that you're masked, being physically distanced, doing, high touch surface cleaning. So getting those Clorox wipes and, wiping down those areas that get touched a lot, doorknobs, if you're in your office, your phone, your mouse pad, your keyboard, your desk chair and desktop, for example. And of course, if you're sick, the days where we would go in and persist through a cold are now gone and over. And even if, you're sniffling and things that, maybe you had attributed to allergies before, I definitely think that while symptomatic, staying home and of course testing is really critical. When will things return to normal? My 8-year-old was asking me this over the weekend. She said that she wants to go back on a plane again. And I said, I couldn't agree with you more. I would love to be able to do that too. I think, we still don't know. I certainly, and this is of my own opinion, feel that until we're able to really vaccinate the children, because they are such a large portion of our population, and because they are often asymptomatic carriers, meaning, they have the virus, but they don't have symptoms. And then they give it to like grandparents who, or parents who then get symptomatic. We're not really going to be able to make too much of a dent here into getting back into normal. And really, pushing vaccinations. And I know that has become a big deal on how one does that. and get more people to get vaccinated. But that really is the key here. I think, things that you can do if, I get it, we want to go back out into eating at restaurants. Certainly, I know my family and I have been doing that, and we eat outside while the weather is still nice and we're able to take advantage of that. When we think about getting a test, it's remembering that a negative test is only negative in that moment. If you test too soon after exposure, it may be negative and then become positive later. So really, that's where if you have symptoms, staying at home is probably just the best thing to do until your symptoms resolve. And again, as we talked about before, right, physically distancing, masking, and, just limiting the amount of things that you do is really the best to decrease your risk. And so those are all the slides that I had. I'll stop sharing so we can all see each other again.
Dr. Smith, there's a couple questions in the chat.
Okay.
Someone asked if you could speak about whether they should check their antibodies and what is the proper antibody test, such as the spike protein test.
Yeah. So, I know there's lots of conversations going around about checking antibodies, and people have been doing that frequently and often. Right now it is not recommended that you check your antibodies. And the reason for that is because the antibodies are essentially, they're checking your B cells, right, which are those cells that develop the antibodies. Those are your memory cells. But there's much more to our immune system and our ability to fight an infection than just the B cells. And those cells aren't cells that currently can be picked up on any blood test. And so and then also, even things like the spike protein test, there are different types of antibodies. So there's something we call neutralizing antibodies. And these are the antibodies that are actually able to fight and kill the virus if you were exposed to it. And these tests they're not testing for the percentage of neutralizing antibodies you have. So even if you have a high titer of spike protein or any antibody titer, depending on the lab test that you do, that can give you a false sense of security because it's not really testing those components of the immune system that are actually helping you to decrease your risk of getting infected should you be exposed.
There is another question in the chat. Somebody is asking, what do you think about home tests? And actually, that's from Robin. If you want to clarify, are you talking about home COVID tests or home antibody tests? Because you're the one who asked the other question too.
Home test, just home COVID test.
Okay. So there are several ways to get a home COVID test. I think there's the rapid antigen tests, which are, sold out of the boxes at like your local pharmacy. And there are, for many of the most common ones, there's now data to suggest how good they are in terms of picking up. So I will say as a whole, most of them are good at picking up positivity if you are symptomatic. If you are not symptomatic, though, the rate in which they pick up someone who is actually positive is very different. The last time I looked, and I don't own stock in any of these companies, but the last time I checked, which was a couple of weeks ago, there's one called Elumi, is the one that seemed to have the best rates of picking up actual positive tests in people who are positive. There are also several, LabCorp, for example, has you do a test at home and then mail it back to them, and you get the PCR results back in like 48 to 72 hours. I think those tests can be good. The rate limiting step with all of them is the technique, right? So depending on the kit, you have to get the swab far enough into your nasal passage to actually get virus should it be there. And that can be hard because it's uncomfortable for people to do when they're doing it on themselves.
Can you talk a little bit, Dr. Smith, about the variants, specifically Delta, and just there's a lot of talk about other variants. And again, that's kind of newer information from when we first met. So can you speak about what that means, what the implications of that could be for the future, and kind of guide us a little bit about that?
Sure. This actually has been a really great way for me to teach my daughter about the Greek alphabet, right? Alpha, beta, delta, gamma. I actually taught myself as well. So the original strain was called Alpha, only we never called it Alpha. We just called it COVID-19, right? And there's been a beta and there's been several others, but you've not heard them being spoken about because they hadn't really changed that much from the original Alpha. So when we talk about a variant, what we mean is that the original virus has mutated, and the amount in which the virus mutates can be very varied. It's part of why every flu season, right, we make sort of educated guesses as to what will be the most prevalent strain. And then the flu vaccine covers as many of those strains as it can. The same is true here for the coronavirus, which is that it can mutate. And the virus mutates when there are not enough people who are protected against the current predominant strain. And so unfortunately, what happened with us is that not enough people got vaccinated in a timely enough manner so that the Delta strain, which had become common, then became more predominant because because it was infecting those people who were not vaccinated. The Delta strain, the variant, and the reason why it has gained so much traction is because it's able to infect people at a faster rate. So whereby before Alpha, which was the more predominant strain, took the amount of virus one needed to be exposed to become positive was much higher. With Delta, the amount of virus is significantly lower. And that's why transmission was happening so much more frequently. We don't think that it is necessarily that it's deadlier, right? We don't think that by getting infected with Delta, you're more likely to die or be at risk for hospitalization. However, it's just transmitted at a much faster rate. And now I think the next variant that they're starting to talk about is the Mu variant. While only in about 5% of cases here in the United States, there was initial talk because it seemed like it spikes, that the virus looked so much different than the previous versions, but that doesn't really seem to be something to worry about right now. One of the when you think about how far science has come, one of the cool things about these mRNA vaccines is that they have the ability to change that protein pretty quickly, so that if we were to get a variant that was so very different from the vaccines that we've already received, they could just change something on that virus relatively quickly, on the vaccine, the protein in the vaccine, to give to us to confer protection against that variant.
Can you talk a little bit about breakthrough cases? Because I think it's something that we're all seeing, and it's definitely hitting closer and closer to home. I imagine most of us on here have heard, either know someone directly or at least have heard of someone who is vaccinated, who does not have a known underlying condition, but has gotten COVID. Yeah.
So my infectious disease friend likes to explain the vaccine like this. She says that, the vaccine is sort of like an umbrella on a rainy day. So while it prevents you from getting soaked, it doesn't prevent you from getting wet. And so that's one of the ways to think about the vaccines for those of us who've received it. The COVID vaccine is that it's preventing us from being it's preventing at least those who do not have an underlying condition from being hospitalized and dying, but it's not preventing us from getting sick. And that's what vaccines are meant to do. They're not supposed to completely prevent an illness, but they're supposed to prevent all of the bad complications from the illness. And because you need such a lower dose of Delta to become positive, it's why we're seeing that happen, much faster than previously before Delta became the dominant strain.
Questions do you all have? Everyone, you can put them in the chat, or you can unmute yourself, or you can physically wave.
So I have a question. It's Nancy. How are you doing? I take letrozole. It's a hormonal medication for my cancer.
Okay.
Do you recommend that I do the booster shot? I mean, I have been vaccinated. I do have an appointment for the booster shot, but is that considered, a high, reason to be, to go for the booster shot, or should I not worry about the booster shot?
Sure. And may I ask, did you receive chemotherapy of any kind?
Oh, yes, I did. I had 24, but it's been now, that was back in 2012, my last chemo.
Okay. Yeah. So I would say you fall under the category of a booster, but not the additional dose. So what we've been doing for the last month or so is giving that additional third dose to people with active cancer, actively on chemotherapy or immunotherapy. And soon, probably by the end of the month, it will be recommended that everybody get a booster dose once you're 8 months past your last vaccination date. And so I think you would fall into that last category, that when it's finally approved at the end of the month, when it's 8 months past your last dose, that you go and get a booster dose.
All right. Well, I have it scheduled for next week on the 21st, but it's only 7 months. The 8 month will be in October. Does it matter, or should I? Okay.
It doesn't.
Okay. All right. Thank you.
Yeah, you're welcome.
There is a question in the chat. What about patients on PARP inhibitors, additional dose or booster?
Additional dose. So I would do it now. You're welcome.
Yes, thank you. What other questions does everyone have? So I'm actually wondering if you can talk, because you mentioned children who are unvaccinated, not eligible at this point. And I think that a lot of us, interact with unvaccinated children, whether it's through work, through our own children, grandchildren, neighbors, we live in buildings. I'm wondering if you could talk about that population a little bit. And I guess also if you have any thoughts on how to protect that population, because at your point, I think in the beginning is really well taken, that one of the best things people can do is to try and prevent the people around you from getting COVID, whether it's through vaccines if they're eligible or through taking precautions. But if you could talk a little bit about that population, and then kind of how to protect ourselves from that population.
Yeah, so I'm certainly living that. I have an 8-year-old and a 4-year-old, and both returned back to in-person school. I kept them fully remote during the pandemic, primarily because I have elderly parents who live with us. And so I was thinking about protecting them, and now I'm like, no, I need to protect my children. So how do I do that? And I think the ways that I do that is that, and the ways that others can do that is that my family and I very much still minimize our interactions and minimize our risk, right? So our summer vacation, we drove there. We're not getting on planes. We will go and do, participate in outdoor activities, but we are avoiding crowds. We are avoiding being unmasked around people who aren't within our, who aren't in our immediate family. I love my sister, and I love my niece who just turned 15, who's like in softball and out and about. And we see them, but we wear masks when we're around them, because that's, what I think we need to do, at least for now, to protect the children. And then the other way around, right, is that now that the kids are back in school, I have to worry about how they may be exposing the elderly parents again, who are now, getting closer to that 8-month time frame in which they need their boosters. And so, it's hard to minimize the contact, right, for a grandmom and their child and their grandchild. But we are, to the extent that we can, we're trying to do that, but we're not doing masks or anything inside the house. Just hoping that we'll get the booster soon enough for them. And I think that's really all you can do. I think at the end of the day, there are things that one can do. We know that mitigates risk: masks, physically distancing, and avoiding crowds, and not being unmasked around folks who aren't in your immediate bubble. What you do outside of that, I think, is very different for each family and based on your own comfort level.
And do you have any inside scoop on when that population might be getting vaccinated?
Yeah, so I just read over the weekend that Pfizer said they're going to submit for emergency use authorization at the end of September for 5 to 12. And Moderna probably won't be until the end of October. And so if we look at the timelines that happened with the adult vaccine or the 12 to 15-year-olds, it's about 4 to 6 weeks after they put in their application that it gets approved. So we're looking probably end of October, middle of November for the Pfizer vaccine for the 5 to 12-year-old crowd. And hopefully very soon after for those that are 6 months to 5.
Thank you. There are a few more questions in the chat. Someone says, so just to be clear, Dr. Smith, the vaccine with a cute little injection icon is not very effective during active chemotherapy treatment? Question mark.
So, right. So it's not as effective as someone who's not on chemotherapy. And how effective it varies depending on the type of cancer you have and the type of treatment you're on. So for those patients who have blood cancers, what we call hematologic malignancies like multiple myeloma, leukemia, we know that their response to the vaccine is much lower than someone who has a solid tumor like breast, ovarian, lung. So when we're talking about the solid tumor population, then it depends on the type of treatment that you're receiving. And depending on the chemotherapy that you get, there are some that lower your immune system much more than others. And so for most of the blood cancers, the vaccine's working at about 20%, unfortunately. For most of the solid tumors, the vaccine is working closer in the 40 to 50% range.
And in that, do the additional doses or the boosters increase that percentage? So again, you shouldn't just give up if you are in that category of someone who wouldn't be as affected. You want to just keep on getting the additional doses you're eligible for. Absolutely.
Absolutely. And that's the whole purpose of that additional dose, is to try and get you up even more.
And that actually leads us into the next question that was posted, which is, please define the difference between booster shot and additional dose for people currently undergoing chemo.
Yeah, so for people currently undergoing chemo, it's an additional dose because two is not enough for you. You need 3, where 2 might be enough for someone who's not on chemo, 3 for someone who is. And then the booster will be for those people who were able to get the 2 doses and had a response. But now after time, we know that that response is going down because, as with anything, we make antibodies for a period of time and then they start to go away. And so the booster are for then those people.
Sorry, so just to clarify then for the folks here, as we do have quite a few who are on active treatment, they can get their 3rd shot, which would be considered an additional shot, but then in theory, they would also be eligible for a booster, which would be a 4th shot on top of that, or does that replace it?
Yeah, in theory, we're not quite, which actually is the question that just came in. And so in theory, that's right, that then you would be eligible for a booster 8 months after your 3rd dose. I think it's still too early to quite know what will need to happen by that point. And also, I believe will probably really be what will probably really be gearing our decisions is what's the dominant strain at the time. Because right now, the Pfizer and the Moderna vaccines that you're getting as an additional dose or a booster dose, it's the same thing you got for dose 1 and 2. It's not any different. And the thought is that by the time we get to 8 months from now, we'll have vaccines that are covering Delta much more than they were covering Alpha or maybe Mu, or who knows what will exist by then.
It sounds like you saw this last question on immunotherapy for lung cancer, received third Pfizer shot on Friday, will booster be required 8 months from now? So I think you did just answer that.
Yeah.
So I'm wondering if you could talk a little bit about what the healthcare system is doing, because I know that there are people who have anxiety about going in for non-essential treatment because they're scared that going into a hospital is actually, or to a hospital or healthcare setting is going to expose them, to more risk, because it is a crowded setting. There might be people around who are immunocompromised. There might be people who are asymptomatic carriers, such as the healthcare team. So I'm wondering if you could maybe talk a little bit about that and what the healthcare system in general, not just Mount Sinai, but healthcare systems are doing to protect patients, especially patients with cancer.
Yeah. So I would definitely say that if there is healthcare that you need to seek, screening, for cancers or any other kind of medical care, that you should not avoid it, that you should definitely be going in to get that care. I think that there are ways in which the things that the healthcare system's doing is, one, we have the ability to do virtual visits or video visits, if appropriate for what you need, right? So to see any primary care doctor, specialist, that can all be done with the video visit. And we have ways to schedule in-home blood tests, so that there are companies that can come to you in your home to check your blood if that's something that's needed for that visit. Additionally, if are services in which you need to go in person to receive, it is mandated at all healthcare facilities that all staff and all non-staff in the facility wear masks. So everyone is masked. We have, this is a challenge in many ways, but have limited visitors, so that places that used to be much busier are not as busy because the visitation policies are in place where that limits the number of people who can come into the facility. And then everyone's doing tons of cleaning. All those high touch surfaces we talked about earlier are getting wiped down constantly. There's so many more hand sanitizers everywhere you look around now. You're Purelling your hands or whatever brand you're using. And so I think that those are some of the things that, help, and also screening, right? So everywhere screening patients before they even come in, so that if you have a symptom ahead of time, we're suggesting that you stay home and come back into us when you're not symptomatic.
So we could probably have time for maybe one more question, if anyone has anything. I'm wondering if you could talk a bit about masks, because I know that there have been, there's a lot of discussion about masks. I believe even in your last talk, we did talk about masks, but, you see a lot of variety in the masks that people are wearing. Surgical masks, cloth masks, some people are double masking, the N95s, the KN95s. So could you speak a little bit about how to choose the most appropriate and efficient and effective mask for certain situations?
Sure. So I think if we look at what exists in the data suggests that there are differing level of masks that are able to keep out different levels of virus particles, right? So a virus is it's in the respiratory droplet. So even when you speak, there are droplets that come out of your mouth. And the ability of different masks to filter out or to keep in different droplets depends on the size of the virus that we're talking about. So if we were going to go from least effective mask to most effective mask, the least effective at filtering out virus particles would be cloth masks on their own, with no filter in it, right? So these are the general cloth masks. And then if we were to move up, that would be cloth masks in which maybe there is a filter, and there's lots of these carbon filters that people are putting in masks, and those filters have differing degrees of the size of virus particle that they're able to keep in or prevent from coming to prevent from coming out or to prevent from coming in. And then you have surgical masks. And surgical masks have also different levels. There's level 1, 2, and 3. And that's how thick they are. And the thicker the surgical mask, the more effective they are at minimizing the droplets from coming in or going out. And then if you continue to move up the chain, we hear a lot about these like KN95s or KN94s, and they can be fairly equivalent to the N95, which is considered the like creme de la creme. That's like the gold star of being able to prevent particles from coming in or going out. The issue with the KN95s are that they, for the most part, are not manufactured in the US, and therefore to testing them to know for sure how much virus they're able to keep out or prevent from coming in is not well known. And so the FDA has a website in which they keep a running list of all of the KN95 masks that are approved, either as emergency use approval or full approval. And they're constantly updating that website. And in fact, I use that website to identify masks to buy for myself, my family, and my children. And so if you are considering buying that level of mask, I would encourage you to do the same, because there's a lot of like knockoffs out there in the world. And so, I think if you wanted to be the most conservative, you would be looking for one of those level masks, whether it's N95 or KN95s, in terms of trying to mitigate your risk at the most. I think for most situations, though, if you're not around large groups, that using a surgical mask in and of itself, one surgical mask, is adequate.
And if you are on, for example, Amazon, there's a big variety just when you type in surgical masks. Are there any kind of buzzwords or things you would want to avoid to make sure? I just noticed that when I've ordered masks from Amazon, there can be a big discrepancy. Just as an example, some of them fit tighter around the nose and have more kind of wire in them, whereas some of them seem to have more plastic and don't bend as much. I mean, again, I don't know how you would know that until you got it in your hands, but I'm not sure if there's anything specific to look for.
Yeah, so the FDA website also lists all of the approved, and it includes the manufacturer and then like the lots. So, you can then match it up to make sure that what's being sold on Amazon is something that is FDA approved or NIOSH, and I can't remember what NIOSH stands for now, but it's NIOSH approved. And that should tell you that that's something that's hospital grade and hospitals would purchase and use.
That's very, very helpful. Thank you so much. I did not know that. And I work in a hospital and did not know that. And as long as we're talking about that, can you talk about face shields? I know that in the hospital, they've now, on the units, they're asking us to wear face shields again, and it had kind of stopped for a while. So could you briefly discuss face shields?
Yeah, so if you want to talk about maximizing or mitigating the risk the most in terms of preventing droplets, the places where droplets will either come into you through your eyes, through your nose, or through your mouth. And so the mask prevents the nose and the mouth. The droplets, the eye protection, the face shields or eyeglasses, whatever you choose to wear, protects the eyes. I will say that the risk of transmission for the general population through the eyes is super low. For us in the healthcare system, because we tend to interact with more people who are sick and more likely to be positive, that's why they added the eye protection to mitigate our risk. And because, of course, they don't want us all to go out and get sick, because they don't want us all to get out and get sick. But then, of course, because then who's going to care for people? So that's why we started doing it again in the healthcare system. And so I don't necessarily think you need to walk around with a face shield or a mask for most situations. But if you were, in a crowded area, like, for example, my mother-in-law, she had to travel for a death in the family, and she wore a face mask and a face shield to mitigate that risk. So.
Thank you so much. Any final questions? We are about out of time. Exactly out of time. I just want to make sure everyone got your questions answered. So, Dr. Smith, thank you so much. This was incredibly helpful. I think hearing this information directly from you, who is so knowledgeable and in the, clearly on the forefront of, the most current information, is just invaluable. So we truly can't thank you enough for your time, for sharing your expertise, for sharing your personal stories and your opinions with us. It was incredibly helpful. So thank you. And thank you all for being here today. I think hopefully you all gained some knowledge that will help keep you and your families safe and get through this challenging time for all. So thank you so much.
Thank you.